Hey, good morning. Welcome to another day in Grand Rounds for Mentoring Functional Medicine. I'm Dr. Patrick Garrett. I'll be your host today. Um, are you presenting? No. Someday she will. She's got good case studies. So, all right. Anybody else? No. All right. Then I guess I'm presenting today. All right, so we have a great case today. This is probably, again, a more common one, and it's a kind of mild one compared to all the stuff that we really deal with. So today's case is case 3, 52-year-old male with gout. And of course, it's more likely to be male, so autoimmune is usually 90% females. Gout is typically going to be guys, typically. Usually, again, big toe, foot, knee, lower. And 6 years of recurrent gout. So again, all they've been doing is chronically managing this. Episodic severe pain, redness, warmth, so dolor, choler, and tumor. In the first metatarsal phalangeal joint, with association of ankle involvement. So for 6 years, just again, toe and ankle pain there. And still managing, again, they're still managing it with 2 medications and then some over-the-counter stuff and still having flares. So again, none of that is fixing any of this. So quality of life impact, obviously, it's very frustrating. He wants to be more active. He can't because his foot hurts. And so patient reports several painful attacks each year, frequently involving sudden nighttime onset. And during severe episodes, even in the pressure of bed sheets is uncomfortable. Like sometimes they put a little box at the end because just even the sheet pressure, just pushing, just a little bit of pushing on there, causes really significant discomfort. And of course, walking is difficult. The recurrent episodes interferes with the sleep, which interferes with exercise and work attendance and travel and recreation. He ain't going nowhere, right? Not with that. He has begun avoiding certain foods and social events because worrying about flares with this. I don't know if you guys deal with this very much, but sometimes gout flares can be pretty traumatic. And because your whole entire upper body rests on that one joint, it can be traumatic. So, very life altering. And then over time, inadequately controlled gout. You'll see this probably more often, of course, in men because men tend to be more, I'm going to be a carnivore and eat a bunch of purines. And if we don't have, I believe, enough B6, it can't convert over into energy through the Krebs cycle. So then the body has to deposit these somewhere. And they deposit as far away from the heart as possible in the brain, so toes. So that's typically why you see it as men. And let's see, medication. So typically he's been doing the allopurinol. He was doing the colchicine, but colchicine actually is one of the handful of drugs that actually increase genetic mutations leading to cancer. So of all the benzene stuff that we talk about for cancer and coal tar stuff we cause for cancer, those derivative ingredients, there's one major drug, well, Tylenol and colchicine, which one's gout, one's for actually fever, not pain. So Tylenol is only for fever. The mechanism for pain is unknown because we completely made it up. So it's kind of a COX-1, but not really. But even in the PDR, it's unknown. So, but it does get rid of fever. And it's the number one cause of kidney failure or liver failure in the United States. And they used to think it was like at least nephroprotective for the kidneys, but now they found it's also just as bad. So, buffering between ibuprofen being the number one cause of kidney failure and then Tylenol being the number one cause of liver failure, they still end up causing a little bit of damage, vice versa. So with allopurinol, that's basically based on the serum urate or uric acid. And let's see, they started less than 100 milligrams per day, and they bumped it up to 300 milligrams a day and still having flares. And then the maximum for that is 800, but I don't think you want that for very long. Now, naproxen's the other one. So naproxen is a COX-2 and COX-1 inhibitor. COX-1, as we talk about with pain modulation and the pain pathways, is not really much of a pain pathway. COX-2 is the pain pathway, but most of the things that we started with, like ibuprofen and aspirin, are COX-1 heavy. So that's why it interferes with kidney, decreases mucus in the stomach, leads to ulcers and bleeding. And so can't do that for very long, and it's not very good at managing the pain, so then they just use more and more and more ibuprofen. But naproxen's got a little bit of balance here now. I don't even know if I'd say that's even better, because Mobic and Celebrex, like Vioxx, got pulled from the market. They used to use Vioxx for gout pain and all pain, but it actually got banned by the FDA because it caused 149,000 heart attacks and strokes during clinical trials that they forgot to report to the FDA. But Mobic and Celebrex didn't lie, so they got approved, but they got a black box warning that says, yay, you can take this for chronic pain, but it's going to increase your risk of heart attack and stroke by 38% in a country with 30 or 50% heart attacks and strokes. So not a great long-term solution, right? And then you can do steroids, corticosteroid injections, but it's going to destroy that joint too. So you can't do that because gout's a long-term problem, long-term dietary problem. So the naproxen, about 500 milligrams by mouth twice a day for acute flares. He said that kind of keeps things down, but he still has breakthrough flares, enough that it's quality of life altering. And then, of course, there's huge GI risk, kidney risk, cardiovascular risk with that. He takes ibuprofen, aspirin for breakthrough too, which is only compounding that. And then usually there's two separate goals. So the standard treatment that we're taught for this in conventional medicine is basically prevent the crystal deposition and let me make sure here. Yeah, manage the attacks and reduce the serum urate. Which colostrum is good for that, but it then causes cancer and genetic mutations, so not very good. So allopurinol does that pretty good too, but again, not great long term. And why is it elevated in the first place? That's our consideration. So basically, lifelong, they keep titrating it, trying to get the serum urate or the uric acid under 6. I like it under 5. But for, again, people that are carnivores, meat-driven, dehydrated, they're just going to build up a lot of these extra crystals because of that kind of philosophy or mentality. And they're going to basically be using medication to manage their dietary problems. So our functional lifestyle medicine approach, always for gout, is, now gout, we'll say it's, I don't know, because we always do, we rarely do supplements, but in this case, we add in a B6 or P5P, so it's reduced, highly absorbable, because that helps convert that over. And then increasing water, and we usually throw in a methyl B12 in there too, because that helps convert methionine and acetylhomocysteine and the glutathione through B6, so it should kind of help that B6 pathway and maybe help with the uric acid breakdown too. So first we want to do a comprehensive intake. So again, the same typical intake that we do. Tell me everything you're eating, drinking, breathing, rubbing on your skin, everything that hurts from head to toe. So we have a whole clinical picture of what's going on, not just the one thing we're presenting at grand rounds today, you know. And then once we have a good picture of diet, we start making little food changes for them, because gout is one that, again, you want to pretty much ditch meat and just be a little bit more vegan with a little bit of meat for flavor. Not huge chunks of meat and a bunch of cheese and no fruits and vegetables and that typical diet. So we got to flip them around a little bit. Can't take away their meat completely. Meat's full of morphine and people will not give up morphine. So you got to let them have their meat, just better meat, anti-inflammatory meat, but less. Meat should flavor. Now, then we do an ELISA test. So always with autoimmune, but with inflammatory problems, we always do that ELISA food sensitivity test anyways, because typically we're dealing with 20 other chronic issues with this person, and that'll quiet those down. And the better people feel faster, the easier they make changes. So then once we know those inflammatory markers, then we remove those foods, and then we go through our basic functional lifestyle medicine approach, which is make drastic changes in their diet and explain comprehensively why we want to make these changes for gout. And then looking at food and environmental chemical toxicities and removing those and really creating simplicity. Reducing stress reactions through neuroplasticity and resiliency. So we typically do that with everyone. And then individualized food reintroduction on little bits, making sure that they're not having any flares, that we actually track the uric acid. We want to keep that below 5. A lot of times when we start, it'll be up really high and it comes down really fast. When you just stop feeding that cycle through that carnivore diet, then all of a sudden you don't have all these excess, you don't have that high demand on B6. And then very quickly, they don't even need the B6 supplements or the P5Ps anymore. So again, our goal is always know what causes it, know what we do to mess up, teach people stop causing that. So the goal for gout is really just stop causing gout, not manage gout. And for this case study, the case outcome was 5 months, and the serum uric acid for this person wasn't too bad. It went from I think it was up around 11 or 12 when we first started, and then it was 8 to 9. Then down to 8.9 milliliters per deciliter. Then at 5 months, we were down to 5.6, which again is below the 6. Still want to see it get a little bit better, so more water, more kind of like fruits, vegetables, nut, seed, berry, legumes, and greens, and a little bit of meat for flavor. That's anti-inflammatory. And then for the gout attacks, there was none during those 5-month follow-up. So very quickly, those gout attacks went away. Because again, you stop causing it and it goes away. So our takeaway for this, again, is gout's not a disease. It's an absolute predictable outcome from your inability to break these down and recycle these or pee them out as excess, so the body has to deposit them. So usually poor diet, long periods of dehydration, lots of beer. Yeah, I guess that's probably the big thing, is the beer and meat is probably our typical gout patient, just so you know. But, they're not doing a bunch of diuretics, not just drinking pots of coffee, drinking tons of beer, depleting and black tea, which is depleting their volume of water to pee out the extra metabolites, and then not putting that uric acid burden in the first place. So we want to balance out urate metabolism naturally, ensure renal excretion, water, and reduce the need or eliminate the need for medication. So he was off his meds by then. Everybody, there's only maybe 3 patients through 20 years that they still want to be on a medication. Most all of them, it's just created to where they don't need medication management anymore, and then they don't need them. And of course, got rid of his beer. His body composition was actually getting better, and so his metabolic health was getting better too. So long-term success is controlling the inflammation and the biochemical condition that permits the crystal formation. So yeah, you probably see a lot of those, but again, most of your healthcare is women, so the occasional man that comes in, it's always kidney stones and gout and maybe erectile dysfunction. That's about it. That's all guys come in for. So you'll usually always have females, but you're not going to see, I don't know if I've seen any gout with a female patient, because they're usually not chugging beer and eating tons of meat. Although that's changing, maybe, so maybe we'll have some gout women, I don't know. But same fix, either way. So know how the body works, know what we do to mess it up, teach people stop messing up. All right, appreciate you guys. Our next case study, what do we have? So we talked about Crohn's, we talked about reversing the girl that sweats blue. We got our gout. Well, this is a long one, so yeah, let's see. So case 4, we have a 41-year-old female with non-alcoholic fatty liver disease who's worried about non-alcoholic steatohepatitis, or what's called metabolic non-alcoholic fatty liver disease and steatohepatitis now. So, all right, hope you guys enjoy this, and I hope this kind of gets you the flow, and it just becomes a lot easier to start implementing this stuff, especially the people who've graduated from the Mentoring Functional Medicine program, or the health coaches too, or just the functional medicine diplomats that attend our stuff. So I hope you guys enjoy Grand Rounds. I'll see you tomorrow.